So what I want to talk about today are three monitoring resources that we use in occupational medicine, and probably as much as anything else that we've talked about in occupational health, because this is really, in most cases, not a work comp issue, it's an occupational health issue. These are three resources that actually are particularly audiometry and spirometry, the third being cholinesterase monitoring. But the audiometry and spirometry actually have fairly significant implications for our group health practices as well, because we will see periodically patients with situations where hearing is impaired or altered on some basis, as well as spirometry, some sort of pulmonary function issue. When we send patients to the pulmonologist, whenever possible, we really ought to be getting spirometry before we send them. If we send somebody to a ear, nose, and throat otolaryngologist, oftentimes sending audiometry is valuable. So these have implications well beyond just occupational health, and therefore I think worth talking about. But in the occupational health world, all three are significant monitoring devices for employees that are exposed to something. In the case of audiometry, of course, it may well be noise issues, hearing impairment. In the case of cholinesterase, we do a lot of monitoring in the Abbott Clinic for employees that are exposed to several categories of pesticides. And in spirometry, we're using a fair amount with folks that have some sort of pulmonary problem, or in the case of doing respirator clearance, sometimes we'll use it there. So they have implications significantly both in occupational health as well as in group health. So clinical applications, as mentioned, today we're going to talk about that, audiometric testing, and some discussion about determining a reportable hearing loss. So looking at, starting off with audiometry, going to talk about the regulatory implications, requirements we have, acoustic trauma, which is exposure to loud noise that impacts adversely one's hearing, and then the evaluation of hearing loss, how we obtain that. How many, Scott or Katie, how many of the clinics have audiometers and can do audiometric testing? Are there others besides Abbott?
Yeah, so let's see, Seaside does, Watsonville does.
What was the first one you said?
Seaside.
Oh, Seaside, okay.
I think it's those three.
Okay. Well, and the thing to bear in mind too, as well as with spirometry, when we get to that, if any of the other clinics have questions where spirometry or audiometry is appropriate, just as with X-ray, in some circumstances where we have resources just in some of the facilities, then sending patients to one of the three is certainly fine. So what goes on with audiometric testing? Well, there's the booth, which you can see, and it has some requirements for attenuation of sound. So the employee, the person with the headset here, steps into the booth and is subjected to various levels of sound at various frequencies measured in hertz. And it's a matter of determining at what level, for each level of hertz frequency, what's the level of sound, the minimum level of sound that can be heard. And so there's a tester that sits outside the booth that works with the patient to send them signals to the headset to determine what frequencies they can hear and what level of sound. And then there's a audiometric report, comes in various forms, but is basically this information where, as you can see at the top, these are frequencies of sound in hertz. And then on the vertical line is in decibels, the level of sound. So when we say 0, we're measuring in relation to that. That represents normal hearing for a particular age. And so if there's a diminution in hearing, then the numbers on the vertical side represent the loss in terms of decibels. And so the higher the number in this range, the greater the hearing loss. And the closer to 0, the better. And we test each ear, and typically there's some mark, in this case, a red circle for the right ear and the blue X for the left ear. And so this represents what the employee can hear at 25, 250, 500, 1,000, 2,000, 3,000, 4,000, 6,000, and 8,000. We generally don't test all these. It's usually 500, 1, 2, 3, 4, and 8. But in any event, these are what the employee can hear sitting in the booth with a headset on and responding to the test levels. So we record it this way. And as just mentioned, the higher the number in decibels, the greater the hearing loss. And so up to 20 decibels is considered to be normal hearing, 20 decibels of loss. From 20 to just under 50, mild hearing loss, then moderate, then severe, and then profound substantial hearing loss. So we make judgments, we assess, quantitate the extent of hearing loss based upon this testing. And this also, for that matter, has some implications in DOT exams, commercial driver license certification, that the employee has some requirements, and we're generally just testing that clinically, not in a booth, and with it is normally a whisper at 5 feet. But occasionally we need to do the testing in the booth for commercial driver's licenses. And then what we do, and this is a little fuzzy, but what we do then, we do at Abbott at least, is record this and make judgments about what the extent of loss, if that exists, what extent there is. And further, what we're doing for those companies for whom we monitor their hearing, we're doing a baseline test when the employee will send them in as a new employee, and we'll establish in this patient named blacked out, you can see at the various levels of frequency, 500 hertz, 1,000, 2,000, 3,000, 4,000, 6,000, 8,000. These are the levels in decibels of what the hearing is for the right ear and for the left ear. And then what we do is also apply an age correction, because as we know, presbycusis, hardening of the tympanic membrane, as any of us get older, typically there's some loss of hearing. And so when we're going to compare hearing from at a baseline, and then later, for whatever reason, the employee sent back in, there will be probably, depending upon what the extent of time difference there is between the two, there may well be some hearing loss that occurs on the basis of age, presbycusis. And so for these to be reasonable to compare, a test at a baseline and then a test a couple of years later, whenever it happens to be done, we need to factor out age-related diminution in hearing. And so what we do is we take the recorded decibel level, then there's an age correction, and NIOSH prints a table to use. So men and women are different. And then for each age up to age 60, there's an age correction that we apply. And so effectively then, for example, at 2,000 hertz, the test revealed a 10 dB loss. The age correction for this 40-year-old person was 6. And so the effective comparable result would be 4 decibels, factoring for age. And then if 2 years later, whatever period of time later, the employee returns for some reason, either they've been subjected to loud noises in the workplace or whatever other reason, Then we do the same thing again, record it, take age correction, and then we've got a corrected hearing loss that we can compare above. And that allows us then to make some judgments as to whether there's a reportable hearing loss. You know, it's possible to have a first report of injury submitted if it appears that the employee has lost hearing based upon workplace noise level. There's a regulatory requirement that any industry that has an 8-hour time-weighted average of 85 dB of ambient sound as measured by industrial hygienists, 8 hours time-weighted. So in other words, they'll take devices and they'll measure over an 8-hour period what the level of noise is, background noise. And if, as an average over those 8 hours, it's at or above 85 decibels, then there's a requirement that all employees subjected to that noise, whichever ones are in the plant that are around that, exposed to that noise, then would be tested annually. And if there is a greater than 10 dB age-corrected STS, which means a change in hearing, and if there's a 25 non-age corrected dB loss, which is the number up here, and it's measured at 2,000, 3,000, 4,000 hertz, then that qualifies for a reportable injury. So we're able to make a judgment as to whether or not the evidence suggests, but it's not confirmatory, that noise in the workplace, assuming the employee isn't exposed to loud hearing elsewhere, then is subjected to that and can create hearing loss just based upon loud noise. And of course, this can happen with kids listening to loud music at concerts or with their headphones or anywhere else. Any of us can be doing this, or folks riding motorcycles, frequently. So in any event, what we're doing then is we're getting a baseline, we're recording the hertz at various hertz levels, what the hearing loss is, we correct for age, and then we take that corrected number. And if either of these does not meet the threshold of threshold change, or the 25 dB corrected loss, non-age corrected loss, then it's not reportable as an industrial injury. So audiometric testing in the clinic. And just as I said a moment ago, workers are required to be tested every year. And actually, the employers are required to provide hearing protection that's appropriate for whatever that hearing, the ambient noise problem is. And that may be earmuffs, it may be plugs. Regulations determine based upon the industry and the level of noise what that protection should be. And so STS standard threshold shift mentioned above, this is the process: testing, age adjustment, make the assessment, compare to baseline, and make a determination. So anyway, and this is available, if we have patients that come in that are non-industrial patients that have some degree of hearing loss and it's not obvious, for example, excuse me, whether there's some sort of cerumen impaction or something, for example, you wouldn't bother with testing there. But we can do testing to make some judgment about the significance of the hearing loss. And by the way, of course, the hearing testing with the audiometer is air conduction. It's not bone conduction. So this doesn't tell us what the reason for the hearing loss is, but it quantitates what the hearing loss problem is. Any questions about any of that? Here's the age correction values table we use and what I just talked about. So cholinesterase, the second type of monitoring we do. In this area and in any ag area, when I was in Fresno, we did a huge amount of pesticide testing. there are a variety of pesticides. And so what we're going to talk about in this small section is some of the categories of pesticide, cholinesterase physiology, which is appropriate to a particular category of pesticide, cholinesterase inhibitors, and then the monitoring we do. So the category of pesticides with which we're concerned are the organophosphates and the carbamates, a particular category of pesticides that are widely used. And acetylcholinesterase, which is a measurable enzyme found in postsynaptic neuromuscular junctions, especially in muscles and nerves, breaks down or hydrolyzes acetylcholine, naturally occurring neurotransmitter, into acetic acid and choline. What happens is in a synapse or at the muscle, the nerve muscle junction, the electric impulse is transmitted through the synapse or into the receptor of the muscle with acetylcholine. And the enzyme that breaks that down is acetylcholinesterase. And that's measurable in the blood. And just graphically where that exists, it exists at the ganglia. It exists in some of the end organs, adrenal medulla, and then also smooth muscle, in contrast to skeletal muscle, the heart, and a variety of glands, and then at skeletal muscle. So this facilitates, in fact, acetylcholine is required for transmission of neurologic impulses. And acetylcholinesterase breaks that down so there's not a continuing bombardment, if you will, of electrical impulses to the end organ. And what happens with cholinesterase, with organophosphates and carbamates, is they impede that. So there is, in fact, a continuing bombardment of electrical impulses and can lead to significant medical problems. And so this is what I just said. These are inhibitors of cholinesterase. Now, the symptoms then, when one sees organophosphate or carbamate poisoning, increased salivation, it's cholinergic symptoms: tear production, diarrhea, nausea, vomiting, small pupils, sweating, muscle tremors, and confusion. Have any of you come across this in the past, either at DOD or elsewhere? And here's a pop quiz. Do you know what medicine we use to reverse this in the clinic when we have it? So it's atropine. We use atropine, injectable atropine, which fairly promptly reverses this. In our prior life, we used to, because we were seeing a fair amount of this, we used to keep atropine in the office, although hardly ever used it. But in any event, the treatment, and when the patient goes to the ER, that's what they're going to get, is atropine. Now, who are the employees that are exposed to this? Well, it's anybody, and covered by regulation, which we'll discuss in a second. It's anybody that deals with organophosphates or carbamates, either in an open, in other words, enclosed or open system. So folks, for example, like the sprayer here, walking around spraying open system, he's spraying some pesticide or some chemical there. Folks that fly the planes that dust the crops with pesticides, others that are on tractors, spraying from the back of the tractors, but then it's also trucks that transport the pesticide, and it's manufacturers of it. So all these folks, by regulation, if they're exposed to organophosphates or carbamates more than 6 days in 30 consecutive days, 6 days out of 30 consecutive days, then are required to undergo testing. And it's primarily for category 1 or 2 pesticides. So there are 4 categories of pesticides, but it's only category 1 or 2. And each of the pesticides is categorized based upon the lethal dose in terms of milligrams per kilogram of body weight of whoever would be exposed. And this is determined largely on the basis of rats, mice, and other mammals. So in any event, employees that are at risk if they're exposed to category 1 or 2 organophosphate or carbamate pesticides, they're exposed 6 days and 30 days, then they're required to undergo testing. And this is national. In California's, we have our own program. And so we draw a baseline, much like audiometric testing. We get 2 or more tests. We take 2 that have a variation of no more than 15%, collected between 3 and 14-day time period, and no less often than every 2 years. And we establish a baseline. And then typically for category 1 or 2 pesticides, we'll do their testing with the employee once a month for 3 months, and then every other month, or as appropriate. And then depending upon the result of that testing, we compare, like audiometric testing, to the baseline. An employee that drops to 80% or less than 80% of RBC or you should say plasma cholinesterase levels, RBC or plasma, because the cholinesterase exists in the membrane of the red blood cells and free in the plasma. We're typically measuring both of those. So if it drops below 80%, then the employer is required to investigate work practices for that employee. If it drops for the RBC cholinesterase to 70%, because that, when there's an exposure, that drops at a slower rate than the plasma cholinesterase. If it drops to 70% and or 60% drop in plasma cholinesterase, then we actually remove the employee from any exposure. They can work, but they just can't work around open or closed systems until, and then we usually have them come back to the clinic trying to determine what the reason for this is. And then we follow them. And typically with both RBC and plasma cholinesterase, if the employee's exposure is removed, they have no further contact for a period of time, both of those will regenerate at the rate of about 1% per day. So if an employee drops 40% to 60, less than 60% of plasma cholinesterase, it's going to take about 40 days with no exposure to return to their baseline level, which is what we're required to do. We're doing really quite a bit of testing. It's wrapping up now because most of the ag in our areas is moving to Yuma or elsewhere, but mostly Yuma. So there isn't much spraying going on right now. But we'll do this, and then we'll start again in February, March, April, whenever employees are going to be exposed. And if they had a baseline established in the prior year, we use that baseline. If it's greater than 2 years, then we establish a new baseline. And most of our employers are pretty good about following this, because the penalties to them of not adhering to these regulations can be fairly stiff. So monitoring, a second form of cholinesterase, a second form of monitoring. And then finally, spirometry, lung function testing. Just going to talk a bit about the measurements and the clinical application of spirometry. And again, as mentioned before, this has application for our patients that have pulmonary disease, and if we're concerned about their inability, if there's adverse lung function. And in fact, we just had a recent case that of exposure to COVID, and there was exertional dyspnea. Patient wasn't getting any better, more than a year out, determined to be MMI, and sent to for a PR4 from rate fast. And unfortunately, we didn't get a pulmonary function on the patient, because that's used in rating patients with exertional dyspnea and other potential lung problems. So spirometry has a variety of applications in terms of the patients we see. Now, what we do with, there's a variety of circumstances where we're using spirometry in the clinic under occupational health. One is just determining baseline of pulmonary function, and that happens in the Abbott Clinic for under two circumstances. One is hazmat exposures, and that's such folks as firefighters and others that are knowingly that they know will be exposed potentially to hazardous materials, as well as pre-placement evaluations for employees that are going to be exposed. It really is two overlapping groups. The second is respiratory clearance evaluations. Most of the time for clearance to wear respirators, we don't need to do pulmonary function, but in circumstances where there's a question about the employee's pulmonary health, then typically we have the leeway to perform that if it looks like it's appropriate. So sometimes we'll do it with pulmonary clearance. And then the third is just assessment of pulmonary function, as mentioned, for example, with COVID, excuse me, for employees that have contracted that disease and that had that exposure, developed COVID lung problems, assessing pathology or other circumstances. For example, sometimes we'll see this in packing plants where there's been an exposure to chlorine, not very often, but occasionally happens, usually a couple of times a year. Employees will come in potentially with some sort of respiratory symptoms, and we'll do spirometry in a situation like that. That actually then, of course, is obviously work comp. So there are two categories. There are three categories of result we determine, we observe. And much like audiometry, it's a way to quantitate a problem, but it does not make a diagnosis for us. Excuse me. So one category is normal results, no problem on audiometric testing. The second is restrictive lung diseases, and these are such as, and restrictive lung diseases are those that impair inhalation, the ability of the lung tissue to expand. And so interstitial lung diseases such as pulmonary fibrosis, sarcoid, obesity, a different sort of disease, and impairs the ability to take deep breaths in people that are potentially morbidly obese. Scoliosis, abnormalities, of course, in the spinal column that may affect the ability of the rib cage to expand. And then some neuromuscular diseases, muscular dystrophy, ALS, some of those. And then there are obstructive lung diseases. And that problem, of course, is those folks that have difficulty exhaling. So it's COPD, also known as emphysema, chronic bronchitis. Then there's asthma, bronchiectasis, cystic fibrosis. All of those are obstructive lung diseases. There's difficulty in exhaling. And how do we observe those clinically? Typically, there will be wheezes, which of course can occur with either restrictive or obstructive disease, but more commonly with obstructive disease, and sometimes stridor from a clinical standpoint. Now, these are lung function measurements. And so this is volume, and these are various portions of the breathing effort. And so the tidal volume is our normal breathing. We're just doing it as each day goes, morning and night. It's, of course, not volitional. We can breathe on a volitional basis, but it's this is what we're doing in the background, periodically taking a deep breath. And then the inspiratory reserve is when we do take a maximum deep breath, it's a reflection of what that volume is. And then a maximum exhalation, a reflection of what that volume is. And so spirometry is giving us some information about the absolute measurements and the relationships between some of these. And we'll go on to a spirometry report in just a sec, but so what we're looking for is two things by and large: forced vital capacity, which is this area here. When you take your deepest breath and your deepest exhalation, then forced vital capacity, and then FEV1, forced expiratory volume 1, that's how much air is blown out in the first second. So it's this portion, how much is blown out in the first, well, if you're starting off with a deep breath, your deepest breath, then how much of this is blown out in the first second. And we measure these in first, second, and third seconds. And so an abnormality will be if there's a diminution in either what's called lowest level of normal, which I'll show you in a second, or if the relationship between FEV1 and FVC is less than 70%. And so graphically representing normal lungs, so in the first second, more than 70% of the air is going to be blown out forcefully, and then it's going to come to a maximum. And so that was the graph you saw. Restrictive diseases, because there's inspiration difficulty, the level, the vital capacity is less. There's less air to be blown out in the first section, and then that peaks at a certain point later than with the normal lungs. And with the obstructive diseases, expiration is a problem. So there's collapse of breathing tubes. Then FEV1 is even lower and peaks at a lower level. And these will be reflected in pulmonary function tests. And so what we do is we gather some information about sex, ethnicity, height, weight, and on the basis of that, we're able to predict what we think FVC, a variety of measurements are, but we're most concerned about forced vital capacity and the forced expiratory volume divided by forced vital capacity. There's a prediction that's made. And then mathematically, there's the lower limit of normal, which will be 70% typically. And then we do a variety of trials, and the best trial obtained, the system will determine that. And then we want it to be greater than the lower limit of normal for FVC, and then this ratio of FEV1 over FVC, at least 70%. So these cases are, and then that's what we record. And then there's some graphs that give us information about the effort and the success of expiration, that exhalation that the employee is doing. And so they're measuring inhalation and then exhalation, and it should lie graphically in between these two lines. And so this represents flow rate divided by the volume of exhalation. And then this graph represents the volume over time. And so ideally employees would be in between these lines. So there's a lot more to that, particularly than we have time for right now. But the point is to understand that this ability to measure exists, and it can be really useful for asthmatics assessing asthmatics. There's a test that's done where bronchodilators are used after the initial test to determine how successful the treatment is in terms of relieving breathing obstruction. So has the regulatory requirement for occupational health, and also useful in the work comp arena. So we could spend a whole hour session on any one of these three, but that's kind of an overview. I think it's important to know that these things exist at the very lowest level, because occasionally, we get calls from employers, can you do this or that, from carriers. Occasionally there will be an issue as mentioned with a PR4. So we at least want to know that these things exist, that they exist, so we can have an intelligent conversation. And then the more we know about them and their application, how to use these resources, we can really bring these potentially into practice, both in the occupational world and the group health world. So think about audiometry, what we talked about, the existence of that as a useful device for evaluating hearing, cholinesterase in the pesticide use world, and then the spirometry for pulmonary problems.